Hi, it's Brandy, Vice President of Clinical Services, and welcome to your new hire orientation. I just wanted to go over the computer stuff. Megan will go over all the clinical aspects of it, but I wanted to get you a little bit familiar with True RCM, which is our computer system. Over here, you'll see it says Mana Health Partners. Over here, it says Mana Health Partners. Down here, it says Mana Health Partners. If anyone, Megan, myself, tell you to email either our support or True RCM support or Mana support, this is the email right down here that you're going to email. So MHP, Mana Health Partners, MHP support at truercm.com. So the reason I didn't log in already because I wanted you to see what the sheet looks like before we log in. So let's get logged in and we'll get started. By this time, you should have already gotten a password and a username. And when you log into the system, it will bring you to the dashboard. On the dashboard, you'll see some icons at the top. It'll tell you how many visits you've done. It'll tell you how many facilities that you're in charge of. You're usually just in charge of one or two. Visits, you'll start out slowly doing 5 and then maybe moving to 10. But they're non-clickable items. They're just there for you to see. Also, as far as monthly snapshots per visits, you can see that on this day I did 13 visits. I do rounds once a week, so that's why mine look like this. Yours should be pretty evened out. But as far as this goes, this is just your dashboard. You'll probably spend about 1 second on your dashboard. Another area that you might find beneficial is under resources. So if you click under resources, under user guides, there will be a whole bunch of videos and PowerPoints. So a lot of them are for different areas that we have. We have facilities in multiple states, and we have different providers. So we have our primary care nurse practitioners, we've got our psychiatric mental health nurse practitioners, and then we've got our LCSWs. So there are just videos that you can scroll down and see if there's anything that's pertaining to you. This one I took out. It wasn't valid anymore. It was out of date. But here's one. Not only can you watch it on YouTube because we have our own YouTube channel, but you can download the PowerPoint presentation. So you might look through this and see if there's any that you could take advantage of. There's a report section that you might want to spend a couple of minutes, maybe twice a week looking at. You're just going to go under reports and then provider. And this is you down here. You're the LCSW daily visit count. So if you click onto here, it will bring up a calendar. And on this calendar, it will show you how many visits that you've done. So it'll have a number here. It also has time because you're based on time, how many minutes you have at the end of the week or how many hours. You can click back into that report section and you can see what your provider bonus is. So for this period of time, you can submit and it will show you your facility and then how many of each visit that you get, and then what your bonus structure looks like. So everyone's bonuses are different, and go in here to see that. Yours actually looks different. If I come to clinical note, it will bring me to 3 different notes. It'll bring me to the nurse practitioner note, the psychotherapy note, and the psychiatric mental health nurse practitioner note. You guys are doing psychotherapy, so your notes would be here. And in this, you have the ability to create an initial note and then create a subsequent note or a crisis note. Now, every first visit you would do would most likely be an initial note. The only exception is if you go in to do an initial note and the patient is in crisis, then you would end up doing a crisis note. So we're just going to come in here and we're going to open and create an initial note. Then we're going to come here to create the new initial. And so it will have my name here. It should be your name. And you can just pick, you don't have to fully spell out their whole entire name. John Smith would probably be John Smith, but if it's Mr. Finkelheimer, I think F-I-N-K would get you close enough to finding which patient you're looking for. So let's see if I can just find a demo patient. I have two of them here. One thing I want to caution you for, especially with our John Smiths and our Jane Does, you may have multiple patients throughout all 100 to 200 facilities that we have that have the same name, especially the more common names. So make sure you verify their date of birth. When you verify that that's the correct patient that you're wanting in the correct facility, then you can click select. Once you select that patient, it should have your facility there. Now, I have multiple facilities, and if you're working in more than one facility, you may have one or two facilities in your drop down. It's very important that you make sure that you've chosen the right facility. So if you automatically defer to the top one and you're in another building, make sure that you verify the building. Just because the patient's in one building doesn't mean that it's going to carry over. So here we've got just my facility and we've confirmed our date of birth. So then we're going to pick our date of service. We ask that you open up each progress note within 24 hours. Same day is preferable, but within 24 hours. 72 hours to close it. There's a rationale not only for a compliance standpoint, but whenever you complete and submit your note, it drops into point-click care and it drops in the minute you submit it. So if your note is a couple of days old, in a chronological order of progress notes, it's not going to be in the right place. So try to make sure that you're getting your notes done in a timely manner. Megan and your supervisors will follow up on that, but it's really important so that the team knows that they've been seen by you and what's going on. So I'm going to pick my date of service for today, and then I'm going to save it as a draft. Once I save it as a draft, it's going to open up the entire note for me. And so a lot of the note you're seeing is blank, but easily rectifiable. I'm going to do my start time. It's 5:30 where I'm at right now. And so I'm going to do my start time. If you have an asterisk that is red, that means it's a required box in order for you to submit your note. I think all of your areas are red asterisks, which means all of these boxes need to be completed in order for you to submit. The I is information of what needs to be in the box or what we're looking for. So this as an initial would be billed out at a 90791. So it's just giving you a little bit of a heads up there. I don't think you have any other I boxes. You do not. So that's easy enough to work with as well. If you type in a box or put your mouse in a box and nothing shows up over here, That means there's no snippets. And what a snippet is a little phrase, paragraph, sentence, statement that's a generalized term. What you need to do with that then is to edit, delete, change wording around to make it fit and be applicable for your scenario. So, for example, referral source, patient was referred by, and then up pop a selection of areas that you could click on. So if the patient was referred by social services, you just click social services and up it pops. If there's someone else that has referred the patient, then you can just hand type that in. If it was a unit manager or somebody like that. I wouldn't use names, I would just use titles. But if there's not a snippet, then you can just hand type it in. And if there is, you're more than welcome to use that. Regarding chief complaint, that's the reason you're seeing the patient. So there wouldn't be a snippet for that. That would be individualized. So you can just type in increased depression, grief, something like that. Under the psychiatric history, there's either a denies or a history of. So patient has a previous or current psychiatric history. So maybe they had a previous psychiatric history of depression with new onset depression. So maybe they had a previous history of depression at 27 years old. I'm just going with this and making it up as I go, but just showing you that this is your template and you can utilize it however you want. Again, if you've spelled something wrong or you don't like it, you can just delete it and then click into it again. Anything you choose. As far as diagnoses go, those would be whatever you're seeing the patient for. So there is a 14-page list of ICD-10 codes that you can use for your diagnoses. Now, the good thing about this program is if you're not too great at spelling, it will catch your spelling issues. So we're going to spell depression wrong. And then we're going to go down. So the red squiggly underneath that indicates that you've spelled it wrong. If you go ahead and put your mouse and right click it, it will give you alternatives. So you can either use the word depression or depressions. So your notes look really formal and really professional. So depression. Psychoactive medications would be any psychoactive medication that you find in the computer that they're taking. So that could be anything from melatonin to Prozac, the Seroquel, any kind of psychoactive medication is really pertinent in your note. If a patient is having depression but they're not sleeping well, is that because they're only sleeping 4 hours and that's what's causing the depression? So any kind of psychoactive medications, list them all. Again, the green or the red squiggly says that I misspelled it. So it's easy to go through and scroll and make sure that your spelling is correct. Any family history. So there's either none or there's significant, or you can write your own that says family history of depression. You could do father, deceased, suicide. So you've got some suicidal family history. You could have just a history of depression, a family history of suicide. Spell that one really wrong and see if it catches me. There we go. Under social history is what kind of support they have. So our social history, especially in a nursing facility, is if they were dropped off and they don't have any friends or family or support. We are saying that this patient has good family support. or that they have a spouse that comes in and sees them and has good support from their spouse, or that they have friends that come in or has good family support from daughter, from 5 daughters, from daughter and son, and from grandchildren. So whatever you want to write, go ahead and utilize, but you can utilize any of the snippets or again, free type them. Functional impairments. This is a very big one. This is how their functional status potentially could impact their psychological status. So a patient requires assistance with ADLs. Why would you put that? Well, because if you were in a wheelchair, would that affect any kind of depression or any kind of anxiety? If you couldn't do things that you used to do independently, would that affect it? So we've given you a couple of samples. Communication, if they're having difficulty expressing themselves, if they have aphasia, if they're mumbling, if they have Parkinson's and have a really soft voice. So any kind of difficulty with communication. And you could even write aphasia. You could write something like soft voice, uh, mumbles, whatever you want. It's all free text here. Um, if they have mobility issues, that can impact them. Or if they don't have any functional impairment at all, then you can click on to that. Any behavioral difficulties, I've given you a lot of them that you can choose from. So agitation, increased agitation or pacing, attention seeking or manipulative behavior, disruptive nighttime behaviors, inappropriate sexual behaviors, physical behaviors. So these are like hitting, pushing, but if they're not hitting and they're just pushing and like slapping, then you can, of course, put that in as well. Um, Coping skills is a good one. They have poor coping skills. And so a lot of what you do is helping them cope and adjust, especially into a facility, a nursing facility. It's a big change for a lot of people. There's one for crying without a clear trigger. There's a diagnosis called PBA where people will spontaneously cry or spontaneously yell out. Loneliness is definitely a difficulty that people face. Over dependence on staff, they're using their call light every 5 minutes. Refusing to participate in care or meals. Let's say it's only in meals, then delete what's not applicable to that so that the sentence or the statement makes sense. So refusal to participate in meals or refusal to participate in peri-care if that's what they're doing, or refusal to participate in showers. So lots of choices, but definitely a lot of ability to increase somatic complaints without etiology, somatic complaints with no medical causes. So either of those you could use, but definitely a lot of choices to choose from. You don't have to have many. You can just have the most applicable or what the patient is going through. And again, you can free type that in. Strengths and resources is something that you're going to lean on as a provider. What kind of strengths and resources are you going to pull from that you know of from the patient that's going to help them get through this? So if they're well educated, that is absolutely a strength. If they participate in activities, is definitely better than being self-isolated. If they're typically compliant, they take their medications. If they're depressed and they are taking their antidepressant, a supportive family is definitely a strength. Relationships, forms relationships, cognitively intact, communicative, hopeful, and motivation. So are they able to communicate and be articulated? Are they motivated for treatment or do they have poor motivation? But again, collect all that you want and list them all out. Liabilities would be the exact opposite. If they're having behavioral issues, if they're having cognition issues, if they're having a physical decline, including related to age, if they've had multiple falls recently and they're just declining. If they're not socializing very much, they were brought to the skilled nursing facility. They had a lot of friends, whether it's church or bingo or different events, and now they're isolating in their room. If they have no family support, that's definitely a liability and a weakness. And if they have none, if they're just doing great in every way, I'm not sure why you're in there assessing them. But if they have no liabilities and no weaknesses, then absolutely put that in there. Emotional and behavioral symptoms, you would assume would pop up a snippet. This is a little bit different because it is located down here. So after every word, there comes a comma. So you can just click in no specific order any kind of emotional or behavioral symptoms. So sleep disturbance with difficulty sleeping, sadness. That way, if you clicked something accidentally, you just unclick it and it disappears. So again, every little statement has a comma after it. So go ahead and write what's applicable. And then the next one is goals of therapy. You're either going to like this one or hate this one. So your goals of therapy, I've got a whole bunch of goals that you can choose from. If you have some that you would like to put into the snippet bank, you can create those for me and email them at the end of this. Or a week in or 2 weeks in or 3 weeks in, or you can make your own Word file document. You probably already have a Word document that you've collected over the years. But what are your goals of therapy? So maybe for one would be coping skills. So first you have your goal. Patient will increase coping skills to reduce anxiety. And then the objective number one is to learn 3 coping skills. And then the objective 2 is to practice 3 relaxation techniques. It doesn't always have to be like that. It could be that this is a brand new patient and you really want them to work on 1 coping skill. So maybe it's 1 coping skill and 2 relaxation techniques. So you're always going to want at least 2 goals that you're focused on. And I tried to paraphrase them. So anxiety decreased symptoms, anxiety stabilize. So you can see the different ones that we have. Anxiety stabilize. So will stabilize anxiety and increase the ability to function on a daily basis. So we'll explore 3 recent stressors that have contributed to a depressed mood and identify and express the consequences of worry. Again, don't feel bad if you want to delete this and add a different objective. I've tried to give you the basics, but again, only when you're looking at each individual patient will you be able to identify what your goals are really going to be. You're going to have to evaluate them, but lots of choices. Feel free to utilize them. If you want to see what they look like, I don't have a Word document because again, I ask people, hey, give me some ideas. So you can just like click on them and see and make a whole big list of them so that you can see what they are. And hopefully that will help you get some good ideas. And again, don't hesitate to reach out if you want me to add something to them. Now, participation is a big deal because if you've got dementia and that's on the diagnosis list, there is an assumption that you would not be able to participate in meaningful psychotherapy. You're not going to remember the therapist from week to week. You're not going to remember the goals from week to week. And so there could be a couple of things that may trigger why you're even seeing the patient. So if I come down to participation, I'm saying that the patient has been evaluated and has the ability and capacity to respond to treatment. I love that. That should be everyone. But some people do have dementia. But remember, there's 8, 10, 12, 15 years that people go through a cycle of dementia, stage 1 up to stage 5 or 6, and it's a very long, tedious journey. So you could be in the early stages of dementia and still be able to participate in a meaningful conversation and participate in psychotherapy. So this is just stating that patient does have a diagnosis of dementia. It's something that we've acknowledged and we're aware they have dementia. That way, if you're ever getting audited and the auditors say, well, this person really had dementia and could they really participate? Yes, they could, because we're acknowledging they have dementia, which is in the mild stage, and patient is able to meaningfully retain their capacity to recall the therapeutic encounter from one session to the other. Otherwise, a dementia patient wouldn't necessarily be able to participate. They'd be happy you stopped by most often, but are they able to participate? Are they able to meet their goals? Another one that some people have difficulty with, and I mean people that are doing survey and audits, is a neurological patient. So this patient has a neurological condition, but they're able to meaningfully retain their capacity to recall the therapeutic encounter. So this could be someone like Parkinson's, someone like Huntington's, someone with like a TBI. Yeah, they have an issue, but they remember who I am and they remember what our goals are. And then the last one is intellectual disability. So I have specifically a patient that has intellectual disability, but is very high functioning and knows my name and knows the day that I come in and do rounds every single week. So she would be able to participate in a meaningful discussion as she does with me on a regular basis. So if they have any of those, dementia, intellectual disability, or neurological, you're going to click one of those. If not, it's got a red asterisk, meaning it has to have something in there. So I've given you this participation one. If you want to free type in there, feel free. Type whatever you want. If you wanted to elaborate on the dementia, you could go ahead and do that as well. The summary of the visit is going to be where you talk about how the visit went. So you may mention how old the patient is, what their diagnosis is, that you discussed previous traumas, you discussed how they ended up in the nursing facility and they don't have anyone to visit, and how their husband has passed away and they're now going through the grieving process. What you don't need to put in here is actual examples. So let's say a patient had a specific trauma that they experienced when they were younger. You don't have to put details of that in there. This is actually going in point-click care, which is HIPAA protected, but do we want everyone to see very, very personal information that the patient and you have as a personal relationship? So make sure you've given us enough of the summary of what's going on with the patient without disclosing very personal information. The next is the prognosis, and we filled it out for you. If this is not accurate, absolutely adjust this. So this just says it is my professional opinion that continued psychotherapy would improve this patient's condition and reduce the patient's psychiatric symptoms, could prevent relapse, could prevent or decrease hospitalization. It could improve or maintain the patient's level of functioning. If psychotherapy was discontinued, it's reasonable that the patient would continue to decline, deteriorate, relapse, or require further hospitalization. And then the patient was present for a portion or all of the visit, which was face to face. So if that is not true, and you do not think that that is accurate, you can say it is my professional opinion that continued psychotherapy services would not benefit the patient, and we will follow up as needed. And that's it. So it's easy enough. There's no snippet over here. It would all be free text. But the gist of this is most people that you're referred to will be able to participate in psychotherapy. If they are not, just go ahead and edit that snippet out, change it up, and just say that it's your opinion that the patient wouldn't be able to participate or wouldn't have meaningful participation in it. Sometimes they're refusing to participate. They don't think they need talk therapy. And by the way, I think everyone needs talk therapy. I think everyone needs somebody to reflect their problems on and deal with coping mechanisms, decrease anxiety, decrease depression. Like there's a lot of different things that LCSWs are so very important for. So as we're going through this note, just know that not only am I working toward this program and working for this program, but I support it 100%. And I absolutely believe whether you're a patient or you're a caregiver, whether you're a staff member, whether you're at the head of the group or the bottom of the group, I think we all need someone to be able to express that too. So it's whether the patient wants to participate or not is really the big part of that. So how much progress do you think that the patient is going to have? So if after your session, there was some progress, like the patient feels better, they're smiling, they were kind of cranky when you got there, but now they're smiling, and in the progress, you feel like you've made a lot of progress, fantastic. If there was excellent progress, that's simple enough because your header says progress and your answer says excellent. If there's a moderate amount, you can click moderate, poor, fair, favorable, or some progress is apparent. Why did I give you a snippet that gave you one word? Well, just to remind you of some of the options there. Do you have to use these? No, absolutely not. You can use any kind of progress that you're seeing for the patient. Frequency of visits. So this is one area that we've been working on to help us write that, but maybe it's 2 times a week times 3 weeks, then weekly. It depends. Maybe it's just once a week. We're going to give you some options here. They just have not been added into the computer system at this point, but we're going to have that on there. I think we had it here. So this is where there was 2 spaces. There was frequency of visit here and frequency of visits here. We have asked the IT to remove this. So if by the time you're ending up doing this program and it's not here, then it did get removed. But some of our choices down here would be like end of life grief support. So the patient or family needed additional support with hospice or after death of a roommate or family. Don't leave both of them. Like pick which one is most important. Can be intensive but time limited. So you're wanting 1 to 2 times a week, just on a short-term basis. You don't know how long that's going to take, but you're not thinking twice a week for the next 52 weeks. You're just thinking a short-term amount of visits. This one is saying the patient requires frequent sessions to stabilize symptoms, support transition, and prevent hospitalization. This should be short-term, then we'll reassess monthly. So this is just saying 1 to 2 times a week initially, and then we're just going to keep evaluating that. And you can actually just copy this and put it into this box as well until that box gets deleted out of there. And if you're going through the program and there's no box, we know that it's been deleted out. Patient presentation and mental status assessment. This is quite extensive. There's no snippet box. That's because these are the check boxes here. A couple of LCSWs saw as a psychiatric mental health nurse practitioner, my mental status and loved it, loved it. So they wanted theirs created this way. So I created it, but I gave you a couple of easy outs with it. So your patient obviously needs to be alert for you to be able to do psychotherapy, and they need to be oriented at least to person. They might not know the time. If you're doing non-responsive or unable to assess, that's probably not the best answer for psychotherapy. Now, here's one that's very hard at times for me. Is the patient euthymic? No, they're on antidepressants. Sometimes they have good days and bad days, but they're not really depressed. Can you use that? So I've got a couple of easy answers down here. They're stable, they're calm, they're balanced, but they could actually be anxious or irritable. Behind each word that you click, there's going to be a comma. So if you decide you want to free text in here, every one of these sections needs to be completed and picked out, and then you can go back and free text. So let's say I want doing great. Their mood is doing great. And then I go to affect. It deletes my statement, doing great. So make sure all of the boxes are filled out, at least one answer for each one. And then you can go back. So let's say suicidality. So reports wants to not wake up. No suicidal intent, no plan, but the patient says they want to not wake up. So that's perfect, and you can leave that. And then if you click on anything else, it will delete it. So let's say I click on calm. There it is. It's gone. So make sure everything is clicked on, and then you can do your free text. I don't know why it does that. It does do that. So I'm just giving you the heads up on that. And you can pick as many as you want. You can pick no hallucinations, with hallucinations, like there's no limit. So make sure that if they are depressed, that we're writing depressed, but not that they have no suicidal ideality, then they do, and then they've got a plan, and then they've got intent, self-harm. So make sure that you're making sure that you're clicking correctly. I didn't mean to say making sure twice. And then when you're all perfect and you're all good, then you free text in there. Type of treatment. I've given you a lot, but I assure you there are so many more that I'm sure I missed. As a psychiatric mental health nurse practitioner, I took 1 semester of psychotherapy. You guys, this is your specialty. So if you have additional things that you want to put in there, you absolutely can. This is not going to support your billing. So if you put supportive therapy, that is not sufficient enough. However, you can use it, and you should be using it if you are doing supportive therapy. And I always click rapport development, because when I'm talking to any of my patients, I'm trying to relate to them and develop that rapport. Exposure therapy, I don't know if that would be good if I was allergic to spiders and you put spiders on me, but there's cognitive behavioral therapy. You don't have to use a ton. You could just use 1 or 2. Cognitive restructuring is very beneficial. Holistic therapy, insight oriented. There's a lot of choices. Again, just not like the click boxes, but just like every other box, you can free type anything you want. Type this area of treatment. So whatever you want to add to it. And so if you're using supportive, remember to add something else. So you should be using, or I would imagine you would be using, a couple of different types of therapy. When I do my psychotherapy at the end of my medication management, I'm definitely doing supportive. I'm definitely doing psycho therapy education regarding medications, but then I'm doing other stuff. So I don't know how many you need. You definitely need more than 1 if you're doing supportive, and maybe 2 or 3 would be sufficient, but no blanket number. You have to have 5 or else. You'll be focusing on whatever your task is for that. Again, your proposed visits, there's a low, moderate, or a moderate acuity, and then there's a maintenance one. So this is just saying every other week they need chronic mental health needs to improve functioning and prevent decompensation. So you've got them stable, you've been seeing them for 2 or 3 months, and now it's okay to see them every other week. So that's what that is. But again, you can free text. The patient requires ongoing support for chronic mental health needs, and you can just say weekly, or you could just delete that out. Weekly times 3 more weeks, then re-eval. So again, free text, whatever you'd like. Your clinical recommendations right down here are these boxes. So what are you going to do at the end of today's visit? Are you going to continue the treatment as planned? Because once you submit this initial and you open up a follow-up, then that data comes over from your last visit into your next visit. So did you adjust the plan of care at all? Did you adjust your goals? Now, did you say, we're going to explore 5 recent stressors? I don't know if I like that. Let's learn 3 new coping skills to reduce anxiety. Something other than cookies for me. That would be a good coping mechanism, is to stay away from the cookies. So we're going to continue the treatment as planned, or you're going to update it. You saw we just updated it so that we're going to do a little bit more, or the patient's absolutely not able to, or they've had a decline, or now they're not communicating, or you can terminate the treatment. Again, you can click all of them. It won't like buzz you or say you can't click all of them. Just make sure that when you're clicking a snippet or when you're clicking a box, that you are aware of what it says and that you're not contradicting yourself. So we're going to continue treatment as planned. That brings us to our ICD-10 code. So I am going to send Megan, along with this video, I'm going to send Megan the 14-page ICD-10 coding for the F codes, the mental health. But most of us know them all. I might have done that too fast, I'm sorry. So here's your ICD-10 codes, and you're going to add. So you're not going to search in here because there's 72,000 entries. So if you need help and it's not on the patient's chart, go ahead and look it up on that 14-page document. But if you know that a patient has anxiety, you can push F41.1, you can click enter, and then it'll give you generalized anxiety disorder. F03.90, it's going to give you dementia. Now, all of these are dementia. All of these are correct. What you're looking for is, what do you want to show up on your note? Because whichever one you pick, and they're all right, you can pick any of them. This says dementia unspecified. This says dementia unspecified. It doesn't really matter. What you're wanting to do is pick whichever one you want to show up on your note. So we'll just pick this one, and then let's do some bipolar. We'll throw that in there. So bipolar, manic depressive, bipolar unspecified. There's bipolar, you can, if there's a mixed state, if there's a manic state, if there's a depressive state. So current episode, if they're in mania, we're going to type this one. And then 5 visits down, they might not have this diagnosis anymore. They might not be manic. They might be depressed and go into that slump. So this might change a little bit, bipolar might, but this is what we're going to find today. And then when you're done picking your diagnoses that you've addressed, So let's say they have 10 diagnoses. They have PTSD from when they were a kid, and they have schizophrenia, and they have bipolar, and they have mood disorder, and they have adjustment disorder, but you're only working on one. Only use the one that you've addressed. So this patient that has bipolar disorder, you have not addressed it anywhere in the notes, so don't put it on there. And that little trash can will delete it out. Same thing with dementia. You haven't addressed dementia. You haven't addressed their problems remembering things. You've really focused on anxiety, and maybe you've focused on some depression. So those are your main issues today. And that's what our goals are today. And probably for the next little while, we've done our treatment plan, and that's what we're focused on is anxiety and depression at this point. It could be grief counseling. It could be a lot of different diagnoses, but let's just use these two for an example. So then, because this is an initial, we already know what the CPT code is going to be. So under CPT code, you're going to click add, and then you're going to click 90791. Now, if you click enter like you're able to do with every other thing in this computer system, it will get you nowhere. And so you're sitting here waiting. This is actually one you have to scroll to the bottom and go to search, and it will pull up the search. Now, I want to clarify how very important your answer is going to be from this. So as of August 15th, that's incorrect. As of July 7th, 2025, that's the correct date. July 7th, 2025. CMS said that if you're using the title of SNF, and it's actually a place of service, that's what they're calling it, a CPT place of service, so POS. If this is an SNF, that means the patient is there under a Medicare stay. Not that they have Medicare somewhere, anywhere, but that they are on a Medicare A stay. So those would be patients you would never see. You wouldn't get reimbursed for a Medicare patient. You would only get reimbursed for a Medicaid patient or a long-term care patient. So that being said, your answer is going to be long-term care or LTC. That is anything other than Medicare. So that is Medicaid, that is hospice. If you have longevity, and Megan will go into explaining the longevity portion of it, but if you've got longevity, anything would be the LTC. If you do, and you are in an assisted living facility, and we do have about 3 of them in Florida that have assisted living facilities, that's what this is, assisted living. We don't do telehealth, Med A, we wouldn't do that. ICF, we're not involved in that. Facility invoice and home health. So really we're looking for this to be the correct answer, and praying that you're not doing a Medicare A visit. That's what this would be. So your answer, 99.999% of the time, is going to be the LTC, and that place of service is 32. So just remember, you are LTC. Remember long-term care. So you're going to select that, and then you're going to X out of there. And now there's your CPT code. So you're going to scroll all the way back up to the top. I don't know why they put it at the top and not the bottom, but your end time, and it's actually 6:11 p.m. right now. And of course, it's going to make me do some math. I'm going to say that it's exactly 40 minutes. I think I'm right. If I'm wrong, do not tell me. So it looks like it's 40 minutes. So I've got my patient, my facility, my date of service, which is today. I saw the patient, not documented, saw the patient at 5:31 and stopped at 6:11. So make sure when you're seeing the patient, you're actually documenting that. It looks like all of my boxes are filled that have red asterisks. Looks like everything. I need a summary here. Some apparent progress. I've got all of these. Remember, every section needs to be filled out, so don't leave one of them blank. And then it looks like my note is perfect. Don't judge me. So then we're going to save it as a draft if you're not all the way done. But if you feel good about this note, if this note is the one you want to use, you can go ahead and submit in a test. When you submit in a test, it does two things. It sends it directly over to Point Click Care, and it gets dropped into their progress notes, and it sends it directly to the billing department. You don't have to do anything but click that submit in a test. Once you do that, it goes right to Point Click Care and right to the billers. If you save as a draft, it will come up under your list of patients that you see. So if you have a note that says visit missing and there's no CPT code and it says that it's in draft, that means you're still working on it. You haven't locked it. So when at the end of the day, make sure that you've locked all of your notes and submitted them. It will tell you the date that the patient was seen last. So in this particular case, I opened this demo patient up back in October of last year. And so now I'm seeing them on 8/21/2025. You can see that again on this patient where I opened the note up on 10/10, and then I did this date of service on May 11th. So we can do a couple of things from here. We can go to the action and we can come back into it and edit it. It brings our note back up and we can finish filling in what we need to and then submit it. We can go to the eye, and the eye is just a visual of what my note will look like. It's not what it'll look like in Point Click Care. In Point Click Care, it'll look like everyone else's notes and it'll blend together. But this is just a bird's eye view of what your note looks like, and to make sure that you like everything. You can go to the print, and I like the print preview screen a lot. Although it doesn't make the prettiest notes, it gives me my ICD-10 codes on the bottom, and then it gives me everything that I didn't see on my my view. So these ICD-10s, for whatever reason, I just like to see what I'm billing out. And then you've got the trash. If you're going to throw it away, this is unlike many programs where you throw it away and then you're like, ooh, I deleted it. Let me go to the deleted notes section under here and fix it and reactivate it, or take that deleted note and copy it because I didn't mean to delete it. That is not one of these. Once you delete, it is deleted forever. You can call IT, you can call me, you can call Megan, you can call anyone in the world, but that note is gone forever. So be very cautious when you put this in the trash can. Know that it is gone and it is gone forever. It's double checking. Are you really sure? Because that note is gone. So if you're not sure if you want to delete it, save it and leave it open, and then make the determination when you're really positive you don't need that note anymore. The note's gone. You won't be able to find it anywhere. IT will not be able to salvage that note. If you come into a subsequent note to create it, you can come in to create subsequent. Say you've already done your initial, and then you go into subsequent note. It will have your patient's name, and you can just start typing the patient's name. And if the patient has a note here already, you can select that patient and it will bring over the subsequent note. Always create a subsequent note from this gray taskbar. I obviously didn't submit any demo patients, so I don't have any to show you. If you create a new subsequent, not only will it allow us to put the name back in, let's say we're going to do the demo patient again, and I think we picked the first one, and the date of service, and we're going to save it as a draft. Nothing comes over. Your whole entire note is blank. So you have to start all over again with your assessments. Whereas if you're creating a subsequent and you select from the initial, or after you're done your initial and you've done a subsequent, it'll give you the initial and subsequent. Pick the last subsequent. And then you do another one, pick the last subsequent. So it will always bring the most current note up to date. And then if you're going to create a crisis note, you can select a previous crisis note if the patient has ever been in crisis, but it will not bring you the initial note, and it will not bring over the last subsequent note. So if you've got a patient in crisis and then a week later they're in crisis again, you can copy this over, but the initial will never copy over to the crisis. So you're just going to start a new note, a new crisis management note on this patient. I'm going to let's select this guy. Here's my facility. I'm going to do it, and I'm going to save this as a draft. This assessment looks very different. Some of the stuff is already filled out. And if you're doing a crisis note, your explanation is this is an urgent assessment of the patient due to crisis. The treatment plan included psychotherapy, mobilization of resources to diffuse the crisis and restore safety, and implementation of psychotherapeutic interventions to minimize the potential for psychological trauma. So it is your opinion that without this crisis visit, that the patient could potentially end up in the hospital, potentially end up with a life-threatening issue, and this patient needs to be seen. So that part is already filled out. If you like it that way, that's fine. If you want to add to it, again, free boxes, type it in. The history is a free type. Your assessment of what's going on is going to be a free type. Your diagnosis is going to be a free type. Do you have to list the 10 psychiatric diagnoses that you're seeing the patient for on a regular basis? Absolutely not. You can see the one reason why you have to see that patient crisis today. Any target symptoms, you're going to fill in here. Your goals of therapy. What are your goals of therapy today? Your goals of therapy are stabilization. Oops. Degree that the patient interacted with a therapist. You can write minimal if they were avoiding you and not making eye contact with you. You can, and maybe that's how they were in the beginning, and then at the end, they were participatory. So you can say minimal, moderate, participated well, whatever your terminology is that you want. Summary of visit. Please be very cautious when you're writing what your summary of visit is. Again, this goes into the medical record, which is very secure and it is HIPAA compliant, both our system as is point-click care. However, you want to be very cautious of stuff that is shared in confidence. So if something is happening to the patient and they're reliving a moment, you can write that in a very judicious way to protect the confidence that the patient shared with you. So you just put your summary of the visit there. And then the progress toward achievement, because of today's visit. So what did you do to change the patient's thinking or their behavior at this point? So this is just saying, and again, it's a blanket statement that you can change. It is my professional opinion that continued psychotherapy services would improve this patient's condition. So this is a crisis visit, okay? But now you're saying I want to see them regularly. So maybe a crisis visit would turn into a twice a week visit for a couple of weeks and then a once a week visit. So it's my professional opinion that continued psychotherapy services would improve the patient's condition and reduce the patient's psychiatric symptoms, prevent relapse or hospitalization, and improve or maintain the patient's level of functioning. If psychotherapy services were discontinued, it is a reasonable expectation that the patient's condition would deteriorate, relapse further, or require hospitalization. The patient was present for a portion or all of the visit, which was face-to-face. So there is because we're asking for progress. So the demeanor is brighter and uplifted. They made excellent progress. They made moderate progress, poor progress, favorable, or just some progress is noted. So we're saying not only do we need to continue to follow the patient, but then how their progress was. Frequency of visits, maybe this is going to be 3 times a week times 1 week. I'm glad for that red squiggly line. And then twice a week times 2 weeks, then weekly. And that's your anticipation. That doesn't have to be what you follow. Maybe next week they're going to need 3 times a week as well because they're on the borderline of crisis. It could be that their spouse just died. And so we're anticipating that they need more assessment and therapy. Patient presentation, again, you've got your little boxes to click. They were alert, they were oriented, something was going on. They obviously weren't euthymic or stable. They were depressed and anxious and angry and sad and irritable, and their affect was sad and tearful and crying, and their speech was hesitant and slurred because they were crying so much and spit was flying. Sorry about that, guys. Any delusions that they're having, any safety issues. If they were having suicidal ideations, absolutely take credit for that. When you're done with everything, no current plan, no intent, patient, stable. So we do want to say that the patient had suicidal ideations, but now they're not. So they're stable. But again, remember to write after everything is all the way completed, because if you click after, it disappears. You only have to do that a couple of times to be like, what? Your type of treatment, again, there's a whole bunch that you can use. If you want me to add some, just let me know. Clinical recommendations. Are you going to continue treatment as planned, treatment plan updated? That would be most likely, or terminate the treatment. And then the amount of minutes that you're going to spend with the patient. So let's say 5 o'clock and then 6 o'clock. And so then you're going to do your ICD-10 of suicidal ideations. Let's say you don't know what that is. Do not look it up here, although I'm not sure what it will say. I look up hypertension and there's 47 of them. Okay, that was easy enough. What did I forget? CPT codes. So if I come into this, and Megan will go through this with you, but if I go through the LCSW PowerPoint, and I pulled this up, there should be a screen. And Megan will go through this, just so you know. So here is psychotherapy in crisis billing. So first of all, initial can only be billed as an initial. You can't add it to it. A subsequent can only be billed as a subsequent. You can't add an initial and you can't add a crisis. And a crisis can only be billed as a crisis. You can't do an initial and a crisis. So all three are separate and distinct exams, and you can't do more than one of them. So for psychotherapy and crisis billing, here's the thing. If you don't spend more than 30 minutes with a patient, you're just going to bill out a regular visit, a 90832. You're going to document under crisis management, but if you don't spend 30 minutes or more, then that's the 90832 here. The 908 or the 90839 is for the first 30 to 74 minutes. So if you've hit 31 to 74 minutes of that, then you're going to use that code. After 74 minutes, add 30 to it. So 74 plus 30 is 104. When you've hit 104 minutes, then you're going to bill this code as well as this code. Both codes are needed. And I'm sure you guys know this already. You guys are super smart, and you have got that all under control. But we're going to, like, for an initial is a 90791. I've given you that little hint on the walkthrough that I just did. And then your subsequent is a 90832, a 90834, and a 90837. So again, nothing can be billed on the same day. So any thoughts to that, let us know. I am going to leave you in Megan's good hands, highly capable. She just wanted some assistance going through the computer program. If anyone has any issues with the computer program, you can reach out. I'll try to help you, but don't hesitate to email IT and ask questions. We're wanting your success here. And we want to do anything that we can and everything to make sure that you're successful in this role. So thank you for letting me share a little bit of time with you. I appreciate it, and I look forward to working with all of you. Have a great day.